Welcome to the APFCB webinar on the role of clinical laboratories in COVID-19. In this lecture, Dr. Sian will be talking on the general aspect of laboratory diagnosis of COVID-19. Dr. Sian received her medical doctor degree from Faculty of Medicine at University of Indonesia, and she is a clinical pathologist from the Faculty of Medicine in the University of Indonesia. She is currently the head of clinical laboratory department at Premium Jatinegara Hospital in Jakarta in Indonesia, and also chairman of Indonesian Association of Clinical Chemistry and board of executive of Indonesian Association of Clinical Pathologists.
Okay, thank you, Rajit. I was asked to present the general aspect of laboratory diagnosis in COVID-19. So the objective of my presentation is the role of laboratory markers in the diagnosis of and management of COVID-19 and the preanalytical aspect, indication, and interpretation of laboratory markers for COVID-19. COVID-19, since first reported in Wuhan in December 2019, and subsequently WHO has declared it as international emergency in January 2020, It now currently the confirmed cases has been 26.8 million already, with around 3 to 4% death. Even though the mortality rate is not so high, but the number of cases and death is a public health concern. COVID-19 is caused by the severe acute respiratory syndrome coronavirus 2, which is a 30 kilobase envelope single-stranded RNA. It's a beta coronavirus, and we know other 6 beta coronavirus that can infect human. And the most popular one is the SARS-CoV and MERS-CoV, which cause severe disease previously reported. And this SARS-CoV-2 virus has 80% homology with SARS-CoV. SARS-CoV-2 virus was transmitted through droplets, but aerosol transmission has been considered responsible also in certain activity. And this virus is transmitted from animal to human in certain cases. The first cases is reported from animal, but the most transmission is from human to human through the entry point through interaction of spike glycoprotein with ACE2 receptor in the respiratory tract, which is a target of specific neutralizing antibody. COVID-19 has an incubation period of 2 to 14 days, averagely 5 days, and clinical manifestation varies from asymptomatic and mild in 90% of cases to severe and fatal in around 5% cases. This differs SARS-CoV-2 from SARS-CoV. In SARS-CoV, mostly are severe disease. And the laboratory roles in the SARS-CoV-2 infection is to stop transmission by screening, surveillance, and monitoring, and in-patient management in the diagnostic, treatment, and discharge of the patient from the hospital. We know certain lab marker that can be used in the diagnostic and management of COVID-19, such as the RT-PCR or the nucleic acid amplification test, the antigen test for SARS-CoV-2, antibody test for SARS-CoV-2, and also some routine lab parameters can be helpful in the management of patient with COVID-19, and also in remote area where lab is not available with many parameters. Viral culture and neutralizing antibody is also laboratory marker that can be used in the infection of COVID-19, but won't be discussed more further in this presentation because it's not used in routine. SARS-CoV-2 virus genome consists of 14 operating frame gene that consists of structural gene for the membrane protein, nucleic capsid protein, spike protein, and envelope protein. Also the replication genes like the operating frame 1AB and other accessories gene. This gene has been these genes in the genome of the SARS-CoV has been used for the target of PCR, like the E gene here, which is the common gene for the coronavirus, and the more specific gene like the open reading frame 1AB, RDRP, and N gene. We know that we will speak about the RT-PCR, antigen, antibody, and routine lab parameters or markers. When the RT-PCR and antigen detect virus from the respiratory tract. So it detects the virus itself. But antibody and routine lab parameters detects the response of the body when the virus enter the body and cause the disease. In the first week, in the incubation period, the viral replicate, and in the first week after symptom onset, it reaches the peak where we can detect the virus by PCR and antigen. And then subsequently, 7 days after the symptom onset, IgM start to be detected, and then followed by IgG. IgG will stay a long time, up to 3 months. For the SARS-CoV-2 PCR, it is considered the gold standard. It detects the SARS-CoV-2 viral RNA. Methods commonly used is the reverse transcriptase polymerase chain reaction, either singleplex or multiplex. But there are also some rapid molecular tests such as the isothermal nucleic acid amplification test, the RT-LAM or RPA. It can produce more rapid result. There are several target genes used in the PCR testing, like the E, N, RDRP, S, and ORF. And sometimes they use combination of these target genes. SARS-CoV-2 PCR is sensitive, especially in the first week after symptom onset, but cannot be used for surveillance because the viral cannot be detected after the second week of after symptom. The disadvantage of this test is it's expensive and not widely available, and it needs BSL level 2 facility with biosafety cabinet level 2 and specific equipment. The RT-PCR, the antigen, the target gene used for RT-PCR, according to WHO, in area with no known COVID-19 virus circulation, we can use 2 different target genes with at least 1 target specific for COVID-19 virus. Or we can use the beta coronavirus target genes, but further identified by sequencing. But in area with established COVID-19 virus circulation, like now already in the whole wide world, screening with a single discriminatory target gene is considered sufficient. Different countries use different target genes. Like we can see here, China used ORF1AB and N. France used 2 targets in RDRP. US used N gene, and German used pan-corona multiple targets and spike protein. Charity used RDRP, ENN, and Hong Kong used open reading frame 1B and SP14NN, and Thailand used and target genes. In Indonesia, we have also different target genes in different laboratory. Viral loads increased in the first week of the onset of the disease, but it started to decrease after the production of antibody. Here, Wolf et al. In their study, they find that it started to decrease in the fifth day, and the detection rate becoming less than 40%. And Wolf also found that the sputum viral load is higher than the nasopharyngeal swab viral load. So after the third week, here we can see that the detection of viral load is already very low. And Wolf also find in his study that after the 8 days, even though positive PCR can be found up to more than 3 weeks, no positive growth in viral culture was found after day 8. This has been considered in many countries for the discharge of the patient after 10 days of no symptoms. Here we can see after 8 days, even though the PCR is still positive, but there is no more positive culture. Kurtika et al. In the literature review and pool analysis has also found that the sensitivity of the PCR test is highest in the first week of symptom, and it decreased and becoming undetectable in the third weeks of symptom. What about antibody to SARS-CoV-2? Antibody to SARS-CoV-2 detect antibody. It can be total, IgG or IgM, against the nucleocapsid protein and spike protein of the SARS-CoV-2. It can cross-react with other coronavirus, and usually generally the seroconversion occurs 7 to 14 days after symptoms appear. First IgM and IgA, and then followed by IgG. In combination with PCR, it can increase the sensitivity of COVID-19 detection, especially at later stage of SARS-CoV-2 infection, where PCR is already negative. It can also be used for surveillance, antibody screening, for convalescence plasma donor, population immunity, and also for risk assessment of healthcare worker. The method detection for the antibody to SARS-CoV-2 can be ELISA, ensembling fluorescent assay, chemiluminescent immunoassay, and also the most popular one is rapid lateral flow immunoassay, which is rapid and available everywhere. The specimen can be from whole blood, serum, or plasma. It depends on the method. In Sir et al. Found in a longitudinal evaluation that more than 95% of COVID-19 patients show seroconversion when tested beyond 8 days after onset of symptom. And the magnitude of antibody depends upon disease severity. The more severe the disease, the higher the antibody. And it varies in declining period depending on the titer. When the titer is high, it declines longer. But when the titer is low, it declines quicker. When the titer is high, it can be detected up to 94 days. IgM and IgG will decline in 20 to 30 days, and IgG is detected up to 94 days. And Sir et al. Also found the correlation of antibody tested against S receptor binding domain or N with neutralizing antibody of SARS-CoV-2. So the higher the antibody tested, the higher also the neutralizing antibody. Reports has been shown that there is a correlation between disease severity and antibody titers. Like here, you can see that in critical patient, the antibody production is higher than in non-critical patient and IgM. Zhao et al. Found in this study that detecting total antibody has higher sensitivity than IgM or IgG. Because we can choose between what marker we will detect, the IgM, IgG, or total, or IgA. What about the sensitivity of the antibody test? Lasanier et al. Studied 3 ELISA and 6 lateral flow tests. And they found that sensitivity is around 33 to 93%, but vary between the specimen collection date. In date 7 to 13, the sensitivity is around 40 to 86%. In day 14 to 20, the sensitivity is around 67 to 100%, increasing. And in more than 20 days, the sensitivity is around 78 to 89%. They find good specificity around 80 to 100%, and positive predictive value around 50 to 100%, 57 to 100%. Sensitivity, specificity, and positive predictive value depends on the types of antibody, target protein, detection format, test sensitivity, time of specimen collection, and also the disease prevalence. Here, Whitman et al. Studies 10 lateral flow assay and 2 ELISA has found the same sensitivity. In the first week of symptom, the sensitivity is low, below 50%, but increase in the second week, and the maximum is in the third week. But it varies between the kit. Some have better sensitivity than the others. But Whitman also found that there is a good specificity around 84 to 100%, depends on the kit. In a systematic review and meta-analysis done, it is found that chemiluminescent assay has better sensitivity in detecting SARS-CoV-2 infection compared to ELISA and lateral flow immunoassay. Here we see it with chemiluminescent assay, it is 98%, with ELISA 84%, and with lateral flow assay is 66%. But the sensitivity found in this study also vary. In the first week, all has low sensitivity, even with IgM and IgG. But it increased in the second week and maximized in the third week. We see here that CLIA chemiluminescent assay has better sensitivity compared to lateral flow immunoassay and ELISA, even in the first week, second week, or third week. And we see here that in the third week, IgG has better sensitivity than IgM. What about the third marker, antigen detection? The antigen detection used a rapid lateral flow immunoassay method with target antigen, spike, membrane envelope, or nucleocapsid protein of the virus. It used the same specimen like PCR, the nasopharyngeal swab. It is simple, easy to test, and rapid, but it should be then done preferably in the biosafety cabinet level 2. But antigen detection has sensitivity lower than PCR and only detect virus at the onset of symptom where the viral load is very high. It is an alternative method where molecular test is not available, especially in the remote area. Mack et al. Found in his study that the detection of antigen in higher viral load with 18.6 is high enough in the nasopharyngeal and throat swab, 81.8 to 80%, but low in the sputum and saliva specimen. But with the normal viral load, with the CT value around 18.6 to 30, the sensitivity is very low, around 0 to 21%. And in his study, Mack also found that compared to PCR, the antigen test is 100,000 less sensitive, 10 to the fifth less sensitive than RT-PCR. So it is used only when the RT-PCR is not available, because it is simple and easy to test. What about the result interpretation? If the PCR positive, it means that currently the patient is infected by SARS-CoV-2 and is infectious because it harbored the virus in the respiratory tract. But it can also mean it is a RNA remnant, especially if it tests in the convalescent state after the 8 or 10 days of symptom. It can also mean false positive if contaminant happen, or if there is infection with other coronavirus, especially when the target gene used is not specific for the SARS-CoV-2 virus. When the PCR test is negative, it means it's not infected by SARS-CoV-2 virus. But it can be false negative in the incubation period or convalescent state in SARS-CoV-2 infection, where the viral load is low or where the viral load is already decreasing. False negative can also be found if there is incorrect specimen type, inadequate specimen collection, inadequate transportation or storage of a viral transport media. In analytic phase, false negative can be found with the method detection by method detection limit, because every test, every kit has different sensitivity or detection limit. And it can cause also by the inhibitors of RNA and pipetting error. False negative can also happen if there is a mutation of the SARS-CoV-2 virus. Using more than one target gene can reduce the false negative caused by the viral mutation. What about antibody? Positive antibody test means that patient already has antibody to SARS-CoV-2. It can mean that patient is currently infected and infectious, but it can mean that the patient is not infectious anymore and not ill anymore, because this is a history of previous SARS-CoV-2 infection. It can also mean that this patient currently or previously is infected by other coronavirus. Positive antibody result can also find if there is interference, like the rheumatoid factor interference or the human anti-mouse antibody interference, or like other interference like hemolysis, ecteric, and lipemic. Negative antibody test can have means that patient doesn't have antibody to SARS-CoV-2. It means that the patient is not yet infected or not infected currently, but it can mean that the patient is infected and harbor COVID harbor the SARS-CoV-2, but he is immunodeficient and cannot produce the antibody. It can also found in the infection of COVID-19 in the incubation or acute phase, where antibody cannot be detected yet. So antibody cannot indicate whether a person is infectious or not, cannot indicate whether the patient is currently ill or not. It should be combined with the PCR. There are other laboratory markers that can be used and help doctors in the diagnosis and management of COVID-19. As we know that SARS-CoV-2 infection can induce cellular and humoral immunity, induce the cytokine production and cause cytokine storm, and it can also cause endothelial damage and cause thrombosis, and also activation of the homeostasis, the coagulation and fibrinolytic pathway, and cause severe acute inflammation syndrome that can cause organ damage. Then all of them can cause abnormality in the laboratory markers, in the routine laboratory markers. In early disease, we will find that white blood cell is normal or reduced. Lymphocyte monocyte is reduced. But when the disease gets progress, we can find also that platelet count reduced and erythrocyte, ESR, and CRP increase. And it can also be seen when the organ is already involved, the increase of liver function tests and renal function tests. Lab markers has also been used for monitoring for disease progression. In the progressive disease, progressive COVID-19 disease, we will see the increase of white blood cells. It can cause leukocytosis and also neutrophilia. And the lymphocyte count, platelet, and hemoglobin further decrease. And there is also increase of the liver function tests, such as ALT, AST, increase of the renal function tests, such as the creatinine and blood, urea nitrogen, and also increase of lactate dehydrogenase. Organ damage also can cause cardiac troponin I increase when there is cardiac involvement in this disease. Activation of coagulation and fibrinolytic cause increase of prothrombin time and D-dimer, and excess inflammation response in the COVID-19 infection cause increase of ESR, CRP, ferritin, and interleukin, especially the interleukin 6. In certain area where not all laboratory marker is available, routine markers such as WBC, absolute lymphocyte, and CRP can be used. In a systematic review, it is found that WBC higher than 10,000, absolute lymphocyte count lower than 10,000, and CRP higher than 10 milligrams per liter is a sign of disease progression. So the doctor should be monitored this routine parameter to see the disease progression. Neutrophil lymphocyte ratio is also found sensitive to detect disease progression. Neutrophil lymphocyte ratio higher than 3.6 is said to have a specificity of 94.1%. COVID-19 cause endothelial dysfunction and also cause activation of coagulation and fibrinolytic. And International Society of Thrombosis and Hemostasis made a guideline using the D-dimer, prothrombin time, platelet count, and fibrinogen for the management of coagulopathy in COVID-19. These 4 parameters can be used to screen patients for admission and monitoring during disease progression. Some score chart has been proposed by different experts, like Song proposed the COVID-19 score chart using the neutrophil lymphocyte ratio and also HS score for cytokine storm that is usually used for the hemophagocytic lymphohistiocytosis. Secondary for detecting the cytokine storm in COVID-19 infection. It is said that HS score more than 169 has a sensitivity of 93% and specificity of 86%. This score, the HS score, use many laboratory markers such as the cytopenias, the triglyceride, fibrinogen, ferritin, and serum aspartate transaminase. For an accurate result, pre-analytical elements is very important. For PCR testing, WHO recommend the upper respiratory tract and lower respiratory tract specimen. WHO recommend nasopharyngeal and oropharyngeal swab, both of them, and or sputum or endotracheal aspirate or bronchoalveolar lavage. The swab should be put in a viral transport media and it's stable for 5 days in 2 to 8 degrees Celsius. The lower respiratory tract specimen should be put in sterile container and is stable for 2 days in 2 to 8 degrees Celsius. Other specimen can also be tested for PCR, such as stool, blood, saliva, and should be put into a sterile container and stable for 2 to 8 degrees Celsius, less than 5 days. In collecting nasopharyngeal and oropharyngeal swab, we should use the flock swab because flock swab collect more epithelial and cellular material eludes rapidly into transport medium. And the swab tip should be made from Dacron rayon or polyester, and we should avoid cotton or calcium alginate. Aluminum or plastic shaft should be used, and we should avoid wood or organic material for the shaft of the swab. And the swab should be put into a viral transport media, storage in 2 to 8 degrees Celsius. If there is a color change in the viral transport media, it should be discarded because it is a sign of deterioration of the viral transport media. It is important for the safety of the staff to use the right PPE, personal protective equipment. If there is no known aerosol transmission, we can use the level 2 PPE. For example, the blood collection. We use the head cap, gown, goggle, mask, surgical mask, and also the gloves. But if there is known aerosol transmission risk, we choose the level 3 PPE. For example, when we collect nasopharyngeal or oropharyngeal swab, or when we induce sputum. Then we should use head cap, coverall, shoe cover or boots, N95 masker, gloves, and goggles. Beside the use of the right PPE, donning and removing PPE is also very important. Report has been shown that infection can occur in the process of donning and removing PPE. We should wash our hands between each action in the removing our PPE. When we collect the swab, especially the nasopharyngeal swab and oropharyngeal swab, make sure that the patient is relaxed and understand what will be done, so they will cooperate. When collecting nasopharyngeal swab, to get a good swab, ask the patient to tilt the head a little and insert swab along the base of the nose until it reaches the wall of the nasopharynx. It is around 4 to 6 centimeter distance, or you can measure the distance between the tips of the nose and the earlobes. Rotate gently when it reaches the nasopharyngeal so that it can collect the epithelium, and swab should be done in both nostrils. For oropharyngeal swab, avoid touching oral wall or tongue. Use tongue depressor if necessary, and swab the posterior wall. Put both swab in 50 ml tube and break the shaft and close tightly, and transport directly to the lab or keep in 2 to 8 degrees Celsius. Specimen transportation should be done as UN 3373 biological substance category B criteria. The viral transport media should be put in a non-rigid leak-proof material in between, and then put again in a rigid outer layer packaging. Identity should be complete, and specimen type, date, time of specimen collection should be also marked down. Transport the specimen in 2 to 8 degrees Celsius using the ice pack. I think that's all for my presentation. Laboratory has important roles in the diagnosis of management and stopping the transmission of COVID-19. But laboratory markers should be chosen and interpreted according to the epidemiological situation, contact history, clinical sign and symptom, and other ancillary tests such as the CT scan. And also, we should consider the resources in every country or every region. Thank you. Stay safe and wear mask. Thank you.